Dear colleagues, today we'll speak about chronic heart failure. I am Dr. Anton Rodionov. Let's begin with the definition of heart failure done by European Society of Cardiology. So heart failure is a clinical syndrome consisting on typical symptoms and signs. We'll speak about it a bit later, due to some structural and or functional abnormality of the heart results in elevated intracardiac pressure or inadequate cardiac output at rest or during exercise. So what does it mean? Symptoms and signs is necessary to make a diagnosis of heart failure. Secondary, that's a structural or functional abnormality. It's important. And next, systolic or diastolic dysfunction, because inadequate cardiac output means systolic dysfunction and elevated intracardiac pressure means diastolic dysfunction. So that's a definition. Heart failure is not a separate disease. It's a complication. It's outcome of cardiovascular continuum. So here in this picture shows so-called cardiovascular continuum, which begins from risk factors. We have spoken about hypertension, about hypercholesterolemia. Then risk factors transfer to coronary artery disease, or that's a novel abbreviation ASCVD, that means atherosclerotic cardiovascular disease, coronary heart disease, or cerebrovascular disease, or symptomatic peripheral atherosclerosis, which cause heart failure and some other outcomes. So heart failure is a complication of practically all cardiovascular disease, and not only cardiovascular disease. Here you can see a non-complete list of causes of heart failure, and absolutely all cardiac or cardiovascular, that will be more true, diseases can as a result leads to heart failure. Coronary artery disease, untreated hypertension, all valvular heart disease, some non-coronarogenic myocardial disease, so-called myocarditis and cardiomyopathies, pericardium disease, and so on and so on. And non-cardiogenic and some systemic disorders, non-cardiac disorders, can also lead to heart failure. You can see here a lot of endocrine, autoimmune disease, storage disorders, toxic lesion, infections, and so on and so on and so on. For example, speaking about toxic lesions, we need to talk about chemotherapy, because now oncology is rather advanced specialties, and they use a lot of drugs which used for malignancy treatments, but most of them can be cardiotoxic. They can cause heart failure in it, and it's a problem. So heart failure is a result of lot of heart disease and non-cardiac systemic disorders. So here you can see a worldwide distributed classification of heart failure. It was created in the beginning of century by New York Heart Association, so it's called New York Heart Association functional classifications, which is very simple, because to establish functional class, you do not need to use special technologies. You just need to talk to the patient and to check their physical activity. There are 4 classes from 1 to 4, and these classifications look like a classification of stable angina. So first class is no limitation of physical activity by ordinary physical activity, and fourth class is inability to perform anything without symptoms of heart failure. So class 2 and class 3, they are intermediate. Class 2 slight limitation, and class 3 marked limitation. So when you see in medical documents heart failure class 2, so you know that we use New York Heart Association classification, which is distributed worldwide. But there is another classification according to phenotypes, which was created in year 2016 by European Society of Cardiology. So these classifications used ejection fraction as an criteria. So by this classification, we divide heart failure on 3 types. Heart failure with reduced ejection fraction, when left ventricle ejection fraction is below 40%. Heart failure with mildly reduced ejection fraction, 41 up to 49% left ventricle ejection fraction. And finally, heart failure with preserved ejection fraction, when ejection fraction is normal or above 50%. So it's important because of different ways of treatment of these types of heart failure. And take a look that to establish diagnosis of heart failure with reduced ejection fraction, you do not need anything except echocardiography. So if you have a patient with breathlessness, with swelling, with reduced heart failure, so that's heart failure with reduced ejection fraction. But for patient with especially preserved ejection fraction, you need to have a data of structural functional abnormalities or raised natriuretic peptides. We'll speak about it a bit later. And last year, American Heart Association introduced so-called heart failure with approved ejection fraction. That's a situation when we treat a patient with low ejection fraction at the starting, and then by our treatment we see how ejection fraction is increased. So that's that we can call heart failure with improved ejection fraction. So symptoms and signs. Let's begin. Heart failure also have some symptoms and signs. Here you can see a list of typical and less typical symptoms. 2 points which is marked by blue color is I would say business card of heart failure. That's more typical symptoms which oftenly is a reason for visiting doctor. The breathlessness and ankle swelling. Yes, except breathlessness and ankle swelling, patient can have orthopnea, nocturnal dyspnea, reduced exercise tolerance, and so on and so on. And right list is less typical symptoms which can be attributed not only to heart failure. And signs of heart failure, more specific signs is due to fluid retention. We can visualize hepatojugular reflux, elevated jugular venous pressure. So it's rather common in right ventricle heart failure. And a list from the right side of slide is a less specific symptoms such as weight gain because of fluid retention, or weight loss in advanced heart failure, cachexia, some cardiac murmur, peripheral edema, and so on and so on and so on. So you can make a stop on this slide and check these signs of heart failure. But despite I told you that breathlessness and ankle swelling, they are case symptoms of heart failure, they does not always reflect heart failure, and we need to perform a differential diagnosis. And I would say it's not as simple. Sometimes when patient comes to me, comes to cardiologist with symptoms of breathlessness. So there are a lot of diseases, not only heart diseases, which can cause breathlessness. Lung diseases. Yes, we study in our course, we study lung diseases, and you know that practically all lung diseases can cause breathlessness. Pneumonia, bronchial asthma, COPD, They are all need to be excluded, and unfortunately sometimes patient can have simultaneously heart failure and some lung diseases. Pulmonary embolism also can be a reason of severe breathlessness. We need to take it in mind. Angina equivalent. Also, it's not a seldom problem. Anemia, often the patient came to us with typical complaints, and they think that they impaired tolerance to exercise is caused with heart disease, but we find an anemia. Obesity. Why that's a question. So sometimes we try to connect heart failure with obesity, and we try to say, so what do you want from us? You have an excess body mass, so you have obesity. That's why you have breathlessness. But patient can answer us. So I had this white for 10 or 20 years, and symptoms are only several weeks. So now we know that sometimes the breathlessness in patients with obesity results to heart failure with preserved ejection fraction. Finally, some drugs can cause such symptoms, such as ticagrelor. While discussing acute coronary syndrome, I told you that ticagrelor is often used as a secondary antiplatelet drugs in patients after myocardial infarction, and there's a not common symptoms, but sometimes ticagrelor intake can cause severe breathlessness just at rest. The same as for ankle swelling. Differential diagnosis of ankle swelling is not very simple. There are a lot of diseases which can cause this symptom, such as venous insufficiency, deep venous thrombus, but double-sided thrombus is extremely rare. So in patients with thrombosis, swelling usually one-sided. Lymphedema, vena cava inferior symptoms, that's a compression of vena cava because of some, most often because of some malignancies, primary or metastasis. Hyperproteinemia due to kidney or hepatic diseases. And again, finally, some drugs. More common edema can be related with calcium channel blockers such as amlodipine or felodipine, nifedipine, dihydropyridine, and calcium channel antagonist, which is widely used for hypertension treatment. The secondary class of drugs is NSAIDs. NSAIDs is very often used in patients with inflammation or pain syndromes such as diclofenac, ibuprofen, and so on and so on and so on. So sometimes they can cause swelling. And there are some other drugs such as antipsychotic which can also cause ankle swelling. So that's an idea. Sometimes differential diagnosis is not so simple, especially when patients are comorbid, as we say. That means that they have several diseases simultaneously. So diagnostic algorithm of heart failure based on symptoms and signs analysis, symptoms and signs, risk factors, and then we need to prove heart failure with two methods, with the lab test on NT-proBNP or BNP and echocardiography. NT-proBNP or BNP brain natriuretic peptide or B-type natriuretic peptide is very sensitive but not so specific for patients with heart failure. That's one European algorithm of diagnostic of heart failure says. So if you think about heart failure, so first of all check BNP level. If BNP is negative, so if BNP level is normal, so heart failure unlikely, and consider out other diagnoses. But if BNP or NT-proBNP elevated, so heart failure is strongly suspected, and do the echocardiography. So what is BNP? Brain natriuretic peptide or B-type natriuretic peptide? Is it good or bad? it is good. So natriuretic peptide system is antidote antagonist of renin-angiotensin system. It's natriuretic, is vasodilatator, it's hypotensive element of our regulative system. So elevation of natriuretic peptide, that means that human organism try to fight with the heart failure, as the same as the temperature in patient with pneumonia. So it is, and we fight not against BNP, but we check BNP level as a mark of severity of heart failure. So elevation of BNP or NT pro-BNP and terminal fragment of BNP is diagnostically meaningful for heart failure. So if BNP or NT-proBNP levels are high, we now do the next step, echocardiography, and we see the systolic and diastolic function. It depends on the result of echocardiography. We establish the phenotype of heart failure. Heart failure, as I told you, with reduced, mildly reduced, or preserved ejection fraction. And then we have a K2 the treatment of this patient. What additional test we need to do? First of all, of course, complete blood count for to exclude anemia, because you remember that low hemoglobin can be a cause of symptoms as a breathlessness. Blood biochemistry, typical number of tests which is necessary for to check the cardiovascular risk factor, and kidney function. I place it for the first position because depending on kidney function we can use or couldn't use some types of drugs. So creatinine and plus estimated glomerular filtration rate, sodium, potassium, uric acid. I hope you know probably that diuretics which I used, which will be used in patients with heart failure, then can elevate uric acid level. Glucose and glycated hemoglobin to exclude diabetes, lipid profile, liver function test, bilirubin, and probably some other tests. Thyroid stimulating hormone is necessary because thyrotoxicosis can be cause of heart failure, or hypothyroidism can be also meaningful. Ferritin, transferrin saturation, and other iron metabolites also should be used. As we told, anemia can be a cause of symptoms, but again, in patients with severe heart failure, we need to correct iron status as necessary. And BNP, we have talked about it. Specialized additional diagnostic tests. Now, first of all, in all patients, we of course need to do standard ECG, 12 leads ECG. It is necessary. It's number one for all patients with suspected heart disease. We can find some rhythm disturbances, conduction disturbances, some signs of chamber hypertrophy, signs of present myocardial infarction, and some electrolyte disorders, and so on and so on. I hope you understand the importance of standard ECG. Transthoracic echocardiography is obvious, and some other tests, additional tests, which could be done in patient with additional indications. Often we use chest X-ray to see the congestion, the lung pulmonary congestion. Transesophageal echo could be done for patient for the best visibility of structure changes. For example, in patient with a valvular heart disease, with patient with suspected infective endocarditis, in patient with suspected thrombus, intracardiac thrombus, and so on. Cardiopulmonary exercise testing, sometimes to differential diagnose the breathlessness. Non-invasive stress imaging Stress echo is preferable, not treadmill test, but stress echo to the best visualization to exclude coronary heart disease. Radionuclide scanning SPECT, that means single photon emission computed tomography, to exclude the amyloidosis first of all. Cardiac magnetic resonance sometimes, and myocardial biopsy. Invasive coronary angiography or CT coronary angiography, and even right heart catheterization in some causes, causes of valvular heart disease. So here you can see the X-ray in patient with heart failure. So here we can see elevated cardiothoracic ratio when the heart is enlarged. Yes, heart is enlarged, and this ratio, heart to the whole chest is more than 50%. Pulmonary venous hypertension, alveolar edema, pleural effusion. So these are signs of heart failure in X-ray. Here's the example of different findings on MRI in patients with different diseases such as hypertrophic cardiomyopathy, amyloidosis, Fabry's disease, and hypertension. So MRI is often used when diagnosis of underlying pathology is unclear. So we need to use MRI. So let's speak about treatment. So treatment goals, as usual in cardiovascular medicine, we have two goals. First, to improve the prognosis, that means reduce hospitalization rate and reduce rates of myocardial infarct, sudden death, and stroke. And the secondary goal is to improve the quality of life. That means improve symptoms, to reduce breathlessness, to reduce edema, and so on and so on and so on. So, patient education and self-care. Yes, of course, we need to talk to the patient about some rather simple things of what to do and what not to do. That means lifestyle modification. First point, to be able to prevent malnutrition and how to eat healthily, avoiding excess salt intake. Of course, the problem of heart failure is fluid retention. This fluid retention is often related to sodium retention. That means that in patients with heart failure as well as in patients with hypertension, we need to reduce sodium intake, no more 5 grams a day. And again, in patients with the severe heart failures, fluid restriction no more than 1.5 or 2 liters a day. Of course, stop smoking, absolutely stop no smoking, including electronic cigarettes, and no smoking environment. Active and passive smoking should be avoided. To be able to abstain from avoid excessive alcohol intake. Of course, alcohol is toxic, is cardiotoxic, and sometimes alcoholic cardiomyopathy is the etiology of heart failure. Regular exercise. The patient should be physically active, even in patient with advanced classes of heart failure. We need to recommend some physical activity which is good tolerate for this particular patient. And immunization for pneumococcus disease and influenza is also very important for elderly patient with some other diseases. So, medicational treatment. Let's first of all discuss the management of heart failure with reduced ejection fraction. With these figures taken from guidelines of European Society of Cardiology. So, first line is 4 groups of drugs to reduce mortality, which must be administered for all patients. So, that's a must. That's also a must. Administer, so every patient must receive at least 4 groups of drugs which reduce mortality, which improve prognosis. These are blockers of renin-angiotensin system, AC inhibitors, or ARNI, I will tell you what is it, beta blockers, mineralocorticoid receptor antagonist, and sodium glucose cotransporter of second type inhibitors. So let's discuss it step by step. AC inhibitors is well known, I hope, for you drugs such as enalapril, ramipril, lisinopril, They are recommended for all patients with heart failure to reduce the risk of hospitalization and death. But you know that these groups of drugs are used widely used as a hypotensive and then can cause hypertension in some patients with heart failure. Blood pressure is normally or even decreased. That's why we need to use small doses as a starting, but then up titrate to target doses, slowly up titration to the highest doses, so to improve the prognosis. If a patient is intolerant to ACE inhibitors, first of all, we speak about dry cough, we can use ARB, angiotensin receptor blockers. That's a group of reserve for patient for heart failure. So here now we'll discuss what is ARNI, and before speaking about ARNI, it's only one drug named sacubitril/valsartan, is drug of double action. We need to remember classical renin-angiotensin-aldosterone system over the right, but over the left you can see system of natriuretic peptides. So I told you that natriuretic peptides, these are good. There's a good system. There's a protective system. And we try to increase activity of natriuretic system. Natriuretic peptides, they are inactivated by enzyme which named as neprilysin. Here's from the left side the NEP. As a neprilysin is an enzyme which inactivates natriuretic peptides, which are good again. Yeah, you remember. So to inactivate neprilysin, we can use molecule named sacubitril. And to reduce the activity of renin-angiotensin-aldosteronic system, valsartan. So this drug was created by Novartis company, and they made a double action molecule. So you couldn't buy sacubitril separately in drugstore. So you can buy only sacubitril/valsartan in one pill. So sacubitril/valsartan is an only one a drug from the group ARNI, named angiotensin receptor and neprilysin inhibitor. ARNI, we use this abbreviation, that means sacubitril/valsartan. So sacubitril blocks neprilysin and increase level of brain natriuretic peptide, and valsartan is angiotensin receptor blocker. So sacubitril/valsartan is recommended as a replacement for ACE inhibitors in patients with heart failure to reduce risk of heart failure hospitalization and death. Sometimes we use ARNI as a first step, not after ACE inhibitors, but as a first-line drugs. It's also possible. But ARNI, unfortunately, can cause severe hypotension. That's a problem of treatment mostly of this patient, because, as I told you, heart failure patient often hypotensive, normotensive or hypotensive, and using drug with blood pressure decreasing potential can cause hypotension. That's a problem. And the second problem, this drug has no generics, it's a rather novel drug, that's why it's rather expensive. And if patient buys the drugs by himself, so it's not always can be done. Second group, so that was renin-angiotensin system blockers. Second group of drugs is beta blockers. Beta blockers should be used in patients with stable heart failure to reduce the risk of heart failure hospitalization and death. But if you remember the classic pharmacology, your classic textbook, so you remember that beta blockers normally then can decrease the ejection fraction. They have a negative inotropic actions. So, and 30 years ago, when beta blockers were created, they was contraindicated to the patient with heart failure because they have negative inotropic effects. But 20 years ago, it was shown that beta blockers in small doses can reduce the sympathetic activity and decrease death ratio in patients with heart failure. That's why we must to administer beta blockers, but again with up titration strategy. So starting doses are very low, and then we slowly up titrating doses of beta blockers up to target doses. So it is. A third group is aldosterone receptor blockers, and let's talk about cardiovascular actions of aldosterone excess. So aldosterone excess is sodium and volume overload. Aldosterone excess is K2 left ventricle remodeling. Electrolyte changes cause arrhythmia, including life-threatening arrhythmia and sudden death, and finally ischemic events. So it's very important to reduce activity, to reduce level of aldosterone to prevent the progression of heart failure and risk of sudden cardiac death. Excessive aldosterone is also leads to fibrosis, to myocardial fibrosis, one of ways of progression of heart failure. So every patient with heart failure need to receive aldosterone receptor inhibitors, or we name it mineralocorticoid receptor antagonist. There are two drugs now approved, spironolactone and eplerenone. In this table you see the third drug, finerenone. Finerenone is used only for now. It's approved only for patients with chronic kidney disease as a nephroprotector and patient with diabetes second type. But now investigation finerenone in heart failure is also continuing. So MRIs are recommended for all patients with heart failure to increase the prognosis, but we need to monitor potassium level because classically mineralocorticoid receptor antagonists can increase level of potassium. So we need to check potassium level to prevent hyperpotassiemia, hyperkalemia. The spironolactone is a less selective drug. That's why high doses of spironolactone can cause adverse events such as gynecomastia or erectile dysfunction in men, mastodynia in females. So that's why it's preferable to use eplerenone in patients with heart failure. And last but not least, sodium glucose cotransporter second type inhibitors is a novel group of drugs which were introduced to heart failure treatment only several years ago. First of all, I need to say that these groups of drugs, SGLT2 inhibitors, so we pronounce it as SGLT2 inhibitors, they were created for diabetes treatment because they influence on proximal channels, and they does influence on glucose reabsorption. They cause glucoseuria, and by mean glucoseuria, they reduce the level of glucose. First of all, they were used for treatment, and until now, they used for treatment of diabetes of second type. But during investigation of SGLT2 inhibitors, it was found that the best prognosis was in patients with heart failure, diabetes and heart failure again. And several years ago, trials were finished when SGLT2 inhibitors was studied in patients with heart failure, irrespectively from diabetes present, and this was shown very good prognosis, improvement of prognosis in patients using SGLT2 type, because SGLT2 inhibitors are not only glucoseuritic but also they cause they are natriuretics, and they have mildly diuretic effects. So empagliflozin and dapagliflozin, they now studies have shown that these drugs reduce the risk of heart failure, hospitalization, and death, and must be used in patients with heart failure. They also have a mild diuretic effect. They have mild hypotensive effect. They have glucose-lowering effect, but only in diabetic patients, and nephroprotective effects. You can ask me, if we use anti-diabetic drugs in patients without diabetes, can it cause the hypoglycemia? No. No, modern anti-diabetic drugs, including gliflozins, SGLT2 inhibitors, they couldn't cause hypoglycemia, whether in patients with diabetes and in patients without diabetes. If a non-diabetic patient intake empagliflozin, dapagliflozin, his blood level will be normal. So no hypoglycemia in patients without diabetes. But there's only one meaningful side effects, is a risk of urogenital infection because of glucosuria. So patient need to have a good genitourinary hygiene to prevent this side effect. So that was 4 groups of drugs which we must give to our patient. Second part of this table is drugs which can be used to improve the symptoms. And first of all, let's speak about diuretics. Loop diuretics. Loop diuretics, they are recommended in patients with heart failure with signs and symptoms of congestion to alleviate heart failure symptoms. Yes, we need to use minimal effective doses. We do not need to up-titrate to the maximal dose as we do with ACE inhibitors and beta blockers. So use minimal effective doses, and potassium supplements are not required. Probably you know that furosemide and torsemide, they can be caused to decreasing of potassium level, but if you combine loop diuretics with MRA and with ACE inhibitors, so there will be a good balance of potassium. You need to check potassium level, but using of loop diuretics are not required of potassium supplements. And in patients with refractory edema, it's possible to combine 2 diuretics of different action. We can, for short time, combine loop diuretics with acetazolamide or hydrochlorothiazides. If channel inhibitors, ivabradine. Ivabradine slows heart rate by an inhibition of the if channels of sinus node. So the properties of ivabradines to reduce sinus rhythm without decreasing blood pressure. That's why ivabradine we can use whether together with beta blockers, whether instead of beta blockers, if beta blockers is contraindicated, or we could give the maximum dose because of hypotension in patients with sinus rhythm. That's an important thing. Often patients with heart failure, they have atrial fibrillation. That's a problem. If a patient has atrial fibrillation, ivabradine is contraindicated. So this drug can be used only in patients with sinus rhythm. Digoxin is the oldest drug which is used until now for heart failure treatment. Digoxin is used more than 100 years. It's the only one drug from groups of glycosides. Commonly, digoxin used for rate control strategy in patients with atrial fibrillation together with beta blockers, but also DIG can be used sometimes in patients even with sinus rhythm, with symptomatic rhythm, as an additional group of drugs, but it's rather seldom. Often we use it together with beta blockers to rate control in patients with atrial fibrillation. Ideally, we need to check a serum DIG concentration, but not available in most countries. So it's this statement is in guidelines, but from the practical point of view, we have no possibility to do it. So we discussed with you management of heart failure with reduced ejection fraction. A pair of words, let's speak about a pair of words about management of heart failure with mildly reduced and preserved ejection fraction. So here you can see that only one drop of drugs, which has a maximal evidence level for this patient, is SGLT2 inhibitors, DAPA and empagliflozin. Diuretics we need to use for fluid retention. All other classes, class 2B, you can use it, not must, but can use it. As for patient with preserved ejection fraction, so here's a statement is the following. Diuretics for fluid retention, we should use. DAPA or empagliflozin SGLT2 inhibitors you must use, and then treat the disease which is an etiology of heart failure. So treat hypertension, treat ischemia, treat atrial fibrillation. So it is. So this the figure how to treat heart failure in patients with preserved ejection fraction. And finally, some additional non-medicational ways of treatment which can be used in patients with advanced heart failure. Cardiac resynchronization therapy. That's a special type of heart stimulation which goes to resynchronization, which is recommended for symptomatic patients with with sinus rhythm and left bundle branch block with a QRS duration more than 150 milliseconds. Yes, morphology of left bundle branch block, and to reduce the dysynchronia of left ventricle. So it can be used. Sometimes patients with advanced heart failure, they die from life-threatening rhythm disturbances from ventricular arrhythmia, ventricular tachycardia, and ventricular fibrillation. To prevent life-threatening ventricular arrhythmia, implantable cardioverter defibrillator could be placed as in primary prevention activity or for secondary prevention. So ICD is recommended for patients who have recovered from a ventricular arrhythmia causing hemodynamic instability. So that means ventricular tachycardia or ventricular fibrillation, or also ICD could be implanted as a primary prevention action in patients with severe heart failure. Other surgical and interventional methods is trying to repair the anatomy of patients with valvular heart disease. That's it with the cardiomyopathies. Some arrhythmologic procedures such as radiofrequency ablation, patient with ventricular rhythm disturbances, with atrial fibrillation, atrial flutter, and so on. Ventricular assisted device often used as a bridge to transplantation, as a special device such as which try to modulate left ventricle, has to help as an additional pump when left ventricle function is decreased. And the last step is heart transplantation, which could be indicated in patients with advanced heart failure, with very severe heart failure, when no other therapeutic option is possible, but the patient should not have contraindication. That means he should have a good prognosis for comorbidity. So no malignancy, no end-stage kidney disease, and so on and so on. That's why heart transplantation mostly used in more young patients with non-coronarogenic myocardial disease. So, dear colleagues, this lecture was based on the latest ESC guidelines, European Society of Cardiology guidelines, which you can download for free from the site of European Society of Cardiology. And let's continue with take-home messages. So, firstly, chronic heart failure is an outcome of large number of cardiovascular and systemic disorders. Diagnosis is based upon symptoms and signs and should be confirmed by echo and BNP level. And treatment to improve prognosis. Treatment, first of all, patients with heart failure with reduced ejection fraction. These are RAS blockers, AC inhibitors, or ARNI beta blockers, mineral corticoid receptor antagonists, and SGLT2 inhibitors. Thank you very much.